Hello, and welcome to the Center for Optimizing Rural Health's December webinar, Implementing New Service Lines, Tips and Strategies You Should Know. I'm Cassidy Avila, and I will be your moderator today during the webinar, and we are so glad that you've joined us. At this time, all participants are set to mute, but if you should have a question during the presentation, we encourage you to go ahead and send it through the chat function. So just open up the chat box and you can send your question to everyone. If you think of something during the Q&A portion, it's fine to go ahead and send it during that time as well. We welcome questions anytime, but we will be addressing them at the end of the webinar. Should you wish to ask a question anonymously, you can choose my name from that drop-down box, Cassidy Avila, and I will ask that question on your behalf. At the end of the presentation, we will share any resources and links that the presenter has mentioned during the presentation. We will also share a short 60-second survey just to get a little feedback from you. So it is now my privilege to introduce our speaker today, Cliff Bottoms. Mr. Bottoms is the owner and principal consultant at CJB Enterprises, a privately held consulting organization. He's a seasoned financial executive with a demonstrated ability to use financial information to drive decision-making and results. He has over 25 years of experience as a CFO and COO executive in transforming financial decisions into transparent, high-performing, and customer service-oriented operations in investor-owned and nonprofit community-based hospitals, as well as public multi-hospital academic healthcare systems. He now uses his experience to help hospitals and other healthcare organizations to reach their potential in management and financial areas. His background has been influenced by the aggressive management of investor-owned facilities, community involvement required in local nonprofit hospitals, and strengthened by the intense public scrutiny of government-sponsored public healthcare systems. He has demonstrated ability to develop strategic business plans, turn them into executable operational and financial plans, and create profitable results. He retired from active day-to-day leadership as CFO for St. Joseph Medical Center in Houston, Texas. And prior to that, he served as Senior Vice President, CFO, and COO for St. Luke's Hospital at the Vintage in Houston, Texas, and Senior Vice President and CFO of the Harris Health System, the fourth largest public healthcare system in the nation. Mr. Bottoms is a board-certified healthcare executive and fills an executive board role with his local American College of Healthcare Executives chapter. Cliff has worked with the CORE organization and the Vulnerable Rural Health Program for 3 years and has provided financial analysis and consultation for over 40 facilities. So welcome, Cliff, and I will give you control now. All right, it is in your hands. Thank you for joining us today.
Well, thank you, Cassidy. And can everybody hear me all right?
You sound great.
Oh, fantastic. Thank you so much. That was a great introduction, probably a little overstated for all the work that I've done over the years, but it's been fun. It's been fun. And as I looked at the list of those that were going to be in here today, there's a lot of diversity in the different facilities that are represented here today. And most of them I have found are the smaller hospitals, and a lot of them are taxing authorities and taxing districts. And I've had an opportunity to spend many years both in investor-owned areas where a lot of aggressiveness in the participation and providing of healthcare and local nonprofits, and also, as you said, ran a very large public healthcare system in Houston, Texas area. It was an organization that for nearly a decade I led, and it had over $1.4 billion worth of revenues every year. And in as many cases, we disproportionate share in tax dollars, received a little over $148 million a year in disproportionate share and upper payment limit money when I was there, and about $360 million of tax dollars that we received every year to take care of folks. I know it on the heart and minds of a lot of people is charity care that they provide, and we provided $660 million worth of charity care every year. And it's kind of staggering when you look at that number and realize that comes down to about $1.8 million of charity care every day that we provided. So you can kind of get an appreciation, and I feel that great appreciation for hospitals that are publicly sponsored in their towns, their communities, their counties, which many of these rural hospitals are. But as you mentioned above, like a good CFO, I was able to spend every last dollar they gave me, and maybe even more so at sometimes. Some people often ask me how I slept at night running some of these larger healthcare systems, and I would tell them that I slept like a baby. I'd wake up every 2 hours crying, and we'd try to get everything taken care of with those hospitals. As I said, when I looked at the potential attendees that we had today, I noticed that many of them were from small and rural hospital and community facilities. Many of them are critical access hospitals. If you are on the call today and you're attending this webinar and you are from a much larger facility, I sure hope that a lot of the things that we talk about today will still work for you and help you in what you're doing from a financial perspective. Let's see if we can get this thing to start to work here. All right. An important message that I need to read for y'all that protects all of us. This webinar is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services under corporate agreement U2BRH 32163. The contents are those of the author, me, and others, and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the United States government. So we're off and running here, I think. Our agenda today, I hope to share with you 6 areas that I find critical when it comes to new service lines that rural and smaller hospitals may be looking at, potential service lines, new service line needs, community needs of the facilities, operational concerns that the facility or organization may need to take into account, financial measures that you ought to be looking at as you prepare for any new service lines and or have introduced new service lines and you want to check and see if they're measuring up to what you thought they would do. And then we'll wrap up with questions and other comments at the end. Potential service lines. Cassidy, I think at this time, you were going to try to put a poll out there that would allow some of the participants to weigh in on any potential new service lines that they may be thinking about doing.
Okay, yes, I just launched the poll. So we invite you to check all that apply in this poll of any service lines that you might have considered or might be considering adding now or in the future. So we'll give you a few minutes to complete the poll.
So as you can see there on the poll, are you considering adding any of these new following service lines? And we'd like for y'all to check all that might apply to you. And as we run through these slides, we'll be polling, and I think we picked out about 10 of all of these that we have. In my working with hospitals and helping them with consulting from all over the nation, we're seeing a lot of services that smaller rural and community hospitals are either have implemented or are thinking about implementing and asking for assistance. We're looking at swing beds, assisted living centers, long-term care facilities, specialty clinics either in their hospital or adjacent to them, wound care services, looking into establishing rural health clinics in the towns they're in or in surrounding towns around them that may help their communities in those areas. A big one that we're seeing is senior behavioral health units that are helping folks of the aged to deal with theirs. Durable medical equipment companies, hospice programs, outpatient rehab centers, advanced diagnostic testing areas and diagnostic testing that the typical hospital may not have in a small rural setting, but are needed for their communities. telemedicine facilities, retail pharmacy, home health, reaching into their community for people that don't really need to come to an acute care facility and need assistance at home, ambulance and transportation services. And I added one during the evening as I was preparing for this that we've seen a lot of people talking about, and in a lot of counties, it's become very, and that's treatment for addiction of pain medications. I have seen in working with hospitals that there's been an explosion in communities of a need to take care of people that have abused pain medications and are now trying to stop and get off that. So we're looking at the polling results, and looks like the winner right now is y'all are all looking into telemedicine components, followed by specialty clinics, rural health clinics. All right, Cassidy.
Okay, great. I will hand it back over to you.
Well, that's a good sampling of some of the different ideas that y'all have in mind out there, things that you're looking about getting into. Let's go to new service line needs. Some of the areas that we're seeing different hospitals commenting upon about why they feel the need for new service lines. Some of it is just purely to increase patient volume. A lot of hospitals and facilities are seeing constraints from the COVID virus. They've seen lost volumes in their hospitals, and now they're looking to see what can we do to maintain volumes in our particular facilities. Capture market share, seeing a need to take market share away from some of your competitors, some of them that may be moving into your area that are causing you to lose market share. Generate new revenues to support hospital operations. There's just so much you can do sometimes with limited inpatient volume, and they're looking to see, are there other ways that we can use our facilities to generate new revenues? Possibly become a hub hospital to multiple rural health clinics. We saw on this poll just recently that you showed that there's interest in setting up rural health clinics in and around your facilities in the city, the county that you may be in, or your portion of the state. And it's a way to drive more volume and business into your hospital and to help the physicians that may be on staff with you. Another way is to stem out migration to facilities in neighboring cities. You may not have the services that people in your community are needing, and you're starting to see them move and go to other places, and you want to recapture that volume that is going to other locations. And it's also very important that a cost analysis and pro forma development be made whenever you're looking at these. And we're going to talk about that a lot more as we go through this presentation today. But it's critical that accurate pro forma products are put together and a cost analysis is made to understand, and then to conduct feasibility studies to see if what we want to do really makes sense in the context of where we are and what our communities are looking for. One of the next areas is to really look deep into what your community needs are. Oftentimes hospitals want to do things that their community doesn't need, doesn't want to support, can't support with volumes. So it's very important that we ask our community, what do you need? Most of the time that is done with a community needs assessment. Most all of us are required to perform this function on a regular basis to see what we and our community need as we go out and talk with them. Another key component is finding out what your stakeholders really desire. I think we all realize that we just become caretakers of our facilities, and oftentimes can be the largest employer in our city, in our community, in our county, and we've got to be very mindful of it. But we have to hear from what our stakeholders desire, and that could be your county commissioners, it could be your city council members, depending upon who your governing body may be, especially if you have taxing authority. We need to listen to the board members. They are often key leaders in our community and have an active interest in what our hospitals and facilities do. Also, we need to listen to other key business leaders. Sometimes there's critical business leaders in our communities that may not be board members, may not be county commissioners, but they're active business leaders that have great influence on the conversation that's going on in our communities, and we need to listen to them. And also we need to talk and listen to our medical staff and see if the specialties that we are looking at are available. Well, you need to recruit for positions if you want to get into a certain service line, or do you already have those specialties taken care of in your town? Are they going to have to be employed positions, or are they in private practice that you can attach to and get things done in your community? And then there's operational concerns. One of them is labor force. Do you have an experienced and trainable labor force in your area for the new service lines that you may be attempting to put into your city? Are they available to work for you? Can you attract them from other businesses in your community if you need to, or do they have the experiences in healthcare that you would be required? What do you do if a person quits, moves to another facility, family moves to another location? Do you have replacement labor in your community that you can quickly hire, that are trainable, that have the skill sets that you'd need to carry on any service lines in your facility, much less any new ones that you have? Or are you only able to provide these services if you have contract labor? If you have to hire a company from the outside that'll provide this labor for you, or if you lose somebody, are you going to have to look for contract labor, which is also oftentimes you have to pay a premium for? The next concern is, do you have available physical space in your facility? Do you have space that you can convert for whatever service you're looking for, or is it going to have to be new construction? Oftentimes, maybe you need to lease space, maybe in a professional building next to you or in some other commercial space in town to run the new service. And is that a viable way of doing that? And as we were talking about a little bit earlier, medical staff specialties. Do you have in your community the medical staff available to do what you need to do in the specialties that are going to be required for your new service line? Are you going to have to share services with hospitals maybe around you in the area to where each of you can share the services of medical staff, where you don't have to employ them full-time, you don't require them on a full-time basis, and you can share them with other facilities and able to attract labor into your area? Or is there going to be recruitment required that can at times take a long time to get, pay a premium to get a position into your community, and then with the hope that you will be able to hang on to them for a period of time to get the project and new service line up and running? And then there's some financial measures that I think we all need to be aware of whenever we decide to start or looking into any kind of new service line. And one of the things I think are most important is to understand the operation and finances of a project and how it impacts the total organization. And part of that is performing a detailed pro forma analysis that would include income statement work, balance sheet work, and cash flow, not only of the project that you are thinking about doing, but would possibly how it would impact the overall operations of your hospital. And so in many consulting engagements that I have done, I've not only looked at the project that they had at hand that they wanted to do and what the income statement, the balance sheet, and the cash flow statement would look like from this incremental project, but also what would that do to the overall financial statements of the whole organization. I'll give you an example of a project that I was doing on the East Coast of a very large university system. And they brought me in to do a financial and operational review of the organization, and also had a very large physician organization attached to the facility. And I'd been there about 2 to 3 weeks, and there was a large meeting of senior executives of the hospital. And the chief operating officer in the meeting asked me, what kind of services do you think that we need to put in this new project that we're doing? And I looked out the window and could see 6 floors of steel outside the building that were going up for a new 10-story patient tower. And I thought it was quite ironic that they were now just getting to the point of trying to understand what operations they need to put in this new 10-story building that they were putting up. And I kind of wondered, how in the world did you ever get your bonds passed if you weren't able to provide them the kind of detailed operational analysis that you were planning on doing? So I think it's very important that as we go through this thing, that we're very honest with ourselves in putting together a very structured income statement, balance sheet, and cash flow statement so that we understand exactly where we are, where we're going, and what we want to do. What I'd like to do now is go through a series of 4 or 5 slides that are different measures that I look at whenever I'm doing work and helping to consult with facilities, and things that I used in the past when I was a sitting CFO, of different measures that would give me some idea of the financial nature of a project that we were going to do. And some of these measures that we're going to go through are good for and should be used on an individual project, but they're also measures that should be used for the total facility in general as to the health of that organization. I'm going to start with 3 measures here that look at profitability of a facility. The first one is looking at total margin, which measures the control of expenses relative to revenues of the entire system. This is kind of, how's the whole enterprise doing in respect to financial profitability. Orient you to how these different slides will be is I've put in the different measures. I have kind of put a definition beside it of what it means and what we're looking at whenever we do this. I've included the formula of how you would get to this measure. And then below it, I've put a national median to how you can take your own organizations and see how you measure up. At the end of this presentation, there is a link to a series of studies that have been done that look at critical access hospitals across the nation that are filing Medicare cost reports that these 3 universities have come together and looked at. And they have looked at the finances of about 1,220 different hospitals in different states. And this report that you'll be able to access and look at later actually goes through a lot of these measures, and it will tell you what the median values are for your state. It'll tell you, how many hospitals responded or in part that they're looking at for these different measures. And it'll give you the median values for that state, and it'll also give you the median value for the nation in whole. And so you can see how you stack up to hospitals in your state, and it'll also give you an idea how you stack up nationwide, and it'll also tell you how your state matches national medians across the nation. So total margin measures the control of expenses relative to revenues, net income, your total bottom line divided by your total revenues. And so it tries to give you an idea of how profitable are you, the national median being about 1.6%. There are many hospitals and many states out there that are not reaching these measures, and could be an area where you'd want to measure yourself against. The next one is cash flow margin, which measures the ability to generate cash. And as many of you have probably heard, that cash is king, and it's understanding if you're putting a project together and looking at a new service line, what kind of cash flow is it going to generate? Oftentimes, many of these do not generate cash immediately. Sometimes it takes them a while to ramp up the volume that you need. Oftentimes, there's going to be a while before you start collecting cash from a new operation and a new service line, because it's time to bill and collect and understand what's going on there. So it's very important that you look at the cash flow coming out of the project, and is it going to help or hurt you? And is it going to hurt you during the short term that you're going to have to be able to cover with other operational items that you have going on? You take the net income, add back in depreciation, which is a non-cash item, and then divide it by the net patient revenues that you expect. And it becomes very important to look at this thing and understand what your net patient revenues are going to be from this new service line. National median being about 5.7% there. And then finally on this slide, operating margin, which measures the control of operating expenses relative to operating revenues. This is an area where you're now starting to just not only look at what's going on in the total, but now you're starting to look at just the operating. Does the operating revenues cover the operating expenses? Another way of looking at this operating margin, it's a way that I've begun looking at a lot of hospitals, is how many dollars of expense does it take to generate $1 of revenue? So I've begun looking at, taking operating expenses and dividing by operating revenues, and just seeing how much expense does it take to generate $1 revenue. And I'm finding that there's some hospitals and facilities out there that, for every dollar that they spend in expense, they're making $1.03 on revenue. Also seeing many facilities out there that for every dollar they spend, they're only making 96 cents of operating revenues. And you can't live very long when you're doing that without significant other contributions to your income statement. The national median being just 0.2%, meaning that we're all working on very, very thin margins right now. And we have to be very mindful of every project that we take on and what we're doing in our operations. One of the mottos that I lived by for many, many years, and you're free to use this whenever you want to, it's not trademarked in any way, is the best way to help the poor is not to be one of them. And so we have to be very strong facilities financially, because there's going to be many people that we're going to need to take care of in our communities that don't have the ability to pay for the services that we provide and they need. And our communities oftentimes will give us tax dollars to take care of those. But I found that the tax dollars that we receive are very important, but it's like the ultimate HMO, that you get a finite amount of money every year, and you're supposed to use that for your operations and capital budgets, but you have to take everybody that comes to you regardless of their ability to pay. The next set of measures that become very critical are your liquidity measures. The first one is current ratio, which I'm sure a lot of you look at, and measures the number of times short-term obligations can be paid using short-term assets. Very simple formula. You take your current assets and you take your current, divide it by your current liabilities. The national median being about 2.5 times, meaning that nationally on median, they have 2.5 times as many current assets as they have current liabilities. Many facilities that I'm working with are not even coming close to this number, it means that, you know, in the long run, it's going to be very tough for them to keep up with paying their vendors, paying wages, being competitive with wages and everything. One thing that I found out that you may want to look at whenever you're measuring this that can really make this number swing from year to year. And I typically, when I'm working with facilities, will look at 3 to 5 years worth of financials to make sure I can see a trend, not just take one snapshot for a year. Is that one area that can really affect this ratio is how you handle your Medicare cost reports when they've been filed. I have seen many facilities where they may have a payable 1 year, which increases liabilities and can make this ratio go down, or they may have a huge receivable, which can make this number look much better. And oftentimes I have seen numbers flip over a 3 to 5 year period once or twice, which makes this number move quite a bit. It becomes very important that we understand and do our cost reports as quickly and as accurately as we can, so that whenever we do have them on our balance sheets, they are an accurate reflection of what we do feel like we're going to need to pay and what we hope that the government is going to pay us. Another thing that I found that will affect this quite a bit is when facilities will go through a business office study, and either they or somebody from the outside will come in and help them in their business office and in billing and collecting, and they will see a large increase in their collections over a short period of time, which can make your current assets go up, turn it into cash, things go up. But what ends up happening is if they don't use those newfound dollars to eliminate their current liabilities, but they either put it into a capital project or something like that, it can really make these numbers change. Days cash on hand. As I told you earlier, cash is king, and keeping up with cash and having cash is very important. Measures the number of days an organization could operate if no cash was collected or received. The formula being total expenses minus depreciation, which is your non-cash expense, and dividing it by the days in the period. Interestingly enough, the national median is having 76 days of cash on hand. Nearly 3 months worth of cash on hand. As I have looked at facilities out there, very few facilities that I see that I've looked at in the states that I've had a chance to look at can get to 75 days. I know it can be a politically tough sell, especially if you're in a hospital that is a taxing authority, a hospital district, whatever it can be, to amass a large amount of money. But it is very important that you have enough cash on hand to handle payroll. Make sure that your days outstanding that you owe others doesn't grow too large. The national median being 75.9 days. Days in net accounts receivable. Once again, all of these measures can be looked at on a per project basis and then looked at enterprise-wide. Net days in accounts receivable measures the number of days it takes an organization to collect receivables. 50.8 days is the national median. You can look at a lot of your different, if you want to look at that report, see where your state stacks up and then look at how you stack up. When you're looking at audited financials, it's very difficult from my perspective to tell, how are they arriving to these numbers sometimes. There are different ways that different hospitals will arrive at a net patient accounts receivable number. Many of them will take a percentage, a historical percentage for inpatient and outpatient, and they'll book that, and then they'll true it up as the receivable gets paid. Many of them can break it down into inpatient and outpatient and emergency room and health clinics and physician offices, and they can get a little bit more detailed, and they can come up with a little bit more defined number that has swing bed days and all sorts of things. And then there's others that have very sophisticated systems and computer programs that can take the DRG that you would have and figure out at the end of every month exactly what I expect to get paid from this patient that has been discharged and rebuilt, or that may be still in-house that will be going out of the facility later. Another area to look at is capital structure. And this can be done on individual projects as well as on the facility, but you're trying to look at, how are we going to finance? Where are we going to get the money to take care of this new service line? If it's going to be physical assets that need to be built, renovated in our facility, lease a facility, whatever that case may be, all of those decisions are going to impact your capital structure and what you're looking at when you get finished. One of them is looking at equity financing. It measures the percentage of total assets that are financed by equity. In other words, your retained earnings. What kind of money have you made over the last few years? And do you have the internal cash and equity position on your balance sheet to fund it internally? Net assets, meaning, as we all know, it's just assets minus liabilities, which equals your equity. In this case, higher is better. A higher number then shows that you're doing quite well financially and that all your organizations and your assets are being financed basically within the cash flow and profitability of your facility. The second one is long-term debt to capitalization. This measures the percentage of your total capital that is debt. Okay, as you look at this measure, national median being about 31%, lower numbers are better here. And that you hope that most of what you're able to do is not the result of having to borrow money to do that, which puts a long-term and a current portion short-term liability on your books, which also impacts your current liabilities and then your current ratio. So when we're looking at these two measures here, we're looking at how much of your capital structure is a result of equity, good performance, or long-term debt where you've had to go into the bond market and borrow money to facilitate your new service line. And then we can look at cost indicators. And this can be looked at, once again, on the individual project basis and something that you should be looking at from an overall macro perspective of your facility each month, quarterly, and every year. Salaries to net patient revenues measures the percentage of patient revenue that are considered labor cost. A good rule of thumb has always been that you should be at or below 50% of net patient revenue. Now, this is one area that I break from traditional GAAP accounting whenever I'm looking at these numbers, especially for you facilities that receive tax subsidies from your county, your city, however your governing body may be. Oftentimes, in a traditional way that audited financials are presented, is that tax subsidies are considered other operating revenues, and they're not considered whenever you come up to a net operating income. I worked for over a decade as I mentioned to you, in a facility that received tremendous amounts of money in tax support to take care of its mission. Many of you are the same way, and I have started including tax subsidies in my net patient revenues here because you're having to hire people and provide services for people that aren't going to pay in the net patient revenue formula, but you're receiving compensation for them from a tax subsidy in the anticipation that you're going to take care of people that are going to come to your facility regardless of their ability to pay. And so over the last few years, I've started to use and include that number here because I think it's a better reflection of the efforts that the facilities are making to take care of the patients in their communities and fulfill the mandate that they're expected to do as a result of receiving the tax subsidies. So in a lot of these measures, I include tax subsidies to see how it looks. The national median is 45.1%. Once again, you can look at those numbers for your facility. You can look at the numbers in your state and see how you stack up. Another key ingredient here is that I do not include, and I don't think we should include, employee benefits whenever we start looking at this number, because employee benefits can be different for different states, for different facilities. It depends on how rich or how lean a facility wants to make their benefits, vacation time, holiday time, call it PTO. What kind of insurance coverage are they going to provide for their employees? Things like that. And so I have specifically take out benefits out of this thing to make sure that I'm looking at what the facility is paying and controlling from an expense side and how they compare to other hospitals from an expense perspective. Another one would be FTEs per adjusted occupied bed. It measures, it's a productivity number. How much are you getting? What kind of productivity are you getting out of the employees that you hired and turning them into full-time equivalents? It's interesting. I've talked to a lot of facilities and they said they don't keep track of adjusted occupied beds. I don't know how you keep up with productivity and how you can compare yourself to others when you're not doing that. But I've found that it becomes even more important to figure out adjusted occupied beds or adjusted daily census, however you may want to call it, especially if you're in a facility that's running an average daily census of 1.5, but you have swing beds that are running 9, you have an assisted living center that you're responsible for, you have multiple long-term care facilities that you're in charge of. And in your audited financials, all of this can be lumped together. You have a home health agency. And so figuring out what your adjusted occupied beds and using that as your divisor in a lot of your different measures then gives you credit for all of that activity that's going outside of the patient bed and the 3 or 4 people you may have in bed on any given day. And so I think it becomes very important that we keep up with adjusted occupied beds and understand how it means and how we use it to judge the overall productivity of our facility. The national median being about 5.6. I always try to be at or below 5, and I felt like much like that, it being 50% of net patient revenues or salary expense was a rule of thumb that let me know when I looked at an organization, are they going to be profitable or are they going to be struggling? And then we look at average age of the plant. And this looks into your capital expenditures that you've been doing for plant, equipment, IT services, and things like that. How old is your plant and are you putting money into it? It just takes accumulated depreciation and divides depreciation expense that's divided into the days of the period. The median being 11.5 years. Of course, lower numbers mean that you have been investing in your facility relatively recently, and you're putting money in your facility. I've seen for some facilities that up around 17, 18 years, which then you can look and see that, for the last 3 or 4 years, they've hardly made any investment in their facility. And it's going to be very hard to attract staff, physicians, people in your community to come to your facility if you have started to defer capital expenditures into your facility. And most of this resolves around other slides that we've seen. What is your profitability? How many days cash on hand do you have? What are your current liabilities and current assets? And do you have the cash flow that you can maintain operations, but then also make investments into your physical structure? As I shared with you earlier, these are a couple of publications that I have used over the last 2 to 3 years as I've been helping Texas A&M and the Vulnerable Hospital Program to study and analyze different facilities. The first one being Critical Access Financial Indicators Report, a summary of indicator medians by state. Excuse me, this is the website that you can go to. It is a lengthy report. It has definitions. It has different ratios that CFOs have come together and have decided are important. And it gives you the medians for different states. It'll tell you how many facilities in that state they analyzed. It'll show you how the different indicators are, and it's many more measures than what I have shared with you today. And it'll tell you how then you can measure how do you stack up to other facilities in your state, and how do you stack up to facilities nationwide. It doesn't have any facility specific information in there that you can see how your neighbor down the road is doing, but it'll give you some idea. And once again, medians, that's the middle number out of an array of numbers. It's not the average or whatever, it's the median number. But you can have an idea where you stand as you speak with your other senior leadership, the people in your facility, your board members, your county commissioners, city leaders, such. You can kind of share with them, and you get to understand how do you stack up. And then there's another one, Small Rural Hospital and Clinic Finance 101. The website, you can link that you can go to there. This has some resources in there, how to do pro forma work and how to build Excel spreadsheets and things like that. If you don't have anything to do, that will help you build a pro forma for your individual service line. And then I would encourage you to make sure that you extend that and take those numbers and weave them into your overall organizational area and see how any particular strategy that you have would influence the overall financial picture of your hospital. With that, I'll open it up for any questions that y'all may have.
Great, thank you so much, Cliff. So at this time, if you have a question, we encourage you to send it to us in the chat. You may be able to unmute yourself if you prefer to ask it out loud, but just know right now you're muted. And I'm going to go ahead and share the links that you had mentioned, Cliff, in the chat box for everyone. So those are live links, and you will be able to just click on them, and it'll take you directly to the the indicators report and then the 101 document. Okay, we don't have any questions yet, but let's go ahead and give it a few more minutes while we're sharing these resources. Okay, so you have those in the chat. And then I would also like to share with you, while we just have a few extra minutes, the survey link. And this survey simply helps us gauge your interest and your need for future webinars and what you might like to see from us. So we would appreciate you taking that. And I see now that they all kind of ran together. So I separated that link out for you as well. Well, Cliff, we don't have any questions at this time. So I think we will give you back 10 minutes of your day. But we sincerely appreciate you taking the time to be with us today. And a huge thank you to you, Cliff, for all of the information that you shared with us and the resources and the links. And if you are thinking of a question and you come up with it after we close today, please feel free to send us a message and we will gladly share that with Mr. Bottoms and get back to you. Thank you so much to everyone that's been on the call. We wish you a happy holiday and wellness throughout the new year. Bye, everyone.